See one, do one, teach one. This is how doctors learn procedures. Let's go. What's up, everyone? Mike Muellner here. I'm an internal medicine doctor from Los Angeles, California, and today we're going to talk about how doctors learn how to do procedures. So already this is kind of a unique topic because learning how to do a procedure on somebody's body is a lot different from learning many other things in life. For example, I might learn a skateboarding trick. Well, I'm not going to hurt anyone. Well, I might hurt myself, but I'm not going to hurt anyone else if I don't do it properly. But with learning a procedure, if something goes wrong, you could seriously injure somebody. And so there's a special way that doctors learn how to do procedures. That's the purpose of this video. So it all starts nowadays with a simulation. So this is something that we didn't really have. It wasn't around 20, 30 years ago. And it was just kind of barely getting started when I was in medical school. But now I think it plays a much bigger role in doctors when they first learn how to do their first hands-on procedures. But some examples of simulation would be like a mannequin. I had one to help me learn how to do procedures like a paracentesis. That's where I take a needle, put it in the abdomen, drain fluid. Before I ever even got near a patient with a needle, I would practice on this mannequin. And so the mannequin was not the most realistic thing in the world. It was basically just like a rubber human belly that had fluid on the inside. And then you would just kind of go through the motions of pretend to sterilize the area, numb the area, and then put the needle with the catheter over it to remove the fluid. And the benefit of this is obviously you're not going to hurt someone if something goes wrong. You're just barely learning this procedure for the first time. But it's also meant to be more of a low stakes situation to help the practitioner, the learner, in this case me, feel more comfortable doing the procedure. Now, one thing that I found, though, is that in any of these simulation sessions, it was not at all like a laid-back experience. First of all, a lot of these simulation mannequins, they're really expensive. The one that would teach you how to run a code blue, it was a full, life-size human mannequin attached to a computer. Amazing stuff. The pupils could dilate and constrict when you shine light on the pupils. It would talk. It would basically interact in many respects like a real human being. I heard it costs like over $50,000. It's very expensive. So it's not something that you can just like willy-nilly borrow for the day and take home and practice with. It was always, these simulation sessions were always in very controlled environments. And so they would feel very formal. And there wasn't any time alone when you could just practice with no one watching. These simulation sessions always had a big group where the instructor would be looking over your shoulder, making sure you do everything right. And sometimes we would even take turns where one student would go in at a time, and then that student really has a spotlight. And then if he or she makes a mistake, the rest of the class can see it. And so you really know who studied ahead of time, who knows their stuff and who doesn't. And so for these reasons, the simulation setting, which should be very low stakes, kind of no big deal, let's get our feet wet, let's get introduced to how to do these operations or procedures, it ends up not really feeling like that. It is kind of a stressful situation. And no matter how good these mannequins get, these simulations get, it's never a substitute for the real thing. It's really how everything feels and just actually doing it when you're in your whole sterile gown in real life, it's a different feeling. So I think that, even still simulation materials, they're great to kind of get your feet wet, get the ball rolling, go through the motions so you have some idea of how the procedure works ahead of time. But it's going to be no substitute to the old school method of learning procedures and operations, which is the see one, do one, and teach one. So let's get into that. And so what it means, it's kind of a shorthand way to say that, first of all, you start with observing. Then you'll start doing the procedure under supervision. And then finally, once you have enough experience with that, then you can teach one. You can teach it to other doctors. It's a lot more in-depth than just see one, do one, teach one. You don't just see one and then do it, or do one and then all of a sudden you're an expert and you can now teach it. It's more like see a whole bunch of them, do a lot, and then you start teaching. I don't think there's any real number that's enforced as a benchmark of mastery, but you definitely need some experience before you move forward in this. So I'll give you an example of lumbar puncture. So this is a procedure that all internal medicine doctors at least have to learn. And I first was exposed to it back in medical school. I saw somebody, I was actually in my pediatrics rotation and saw one of the new residents do a lumbar puncture for the first time. And so to explain the procedure, what it is basically you take a long needle and then you use landmarks, you palpate the spine and find right at about the level of L4 in the lumbar spine. That's where you want to go in just under that with a spinal needle, insert the needle right in between the vertebrae, and then get it angled just right, and then you can drain cerebral spinal fluid. And then before that, you do all the normal procedural stuff, like get dressed up in a sterile gown, like a surgical gown, put on sterile gloves, and have the area cleaned, numb it with lidocaine, etc. And so that's the procedure. And I saw it first done when I was in medical school. And I remember the resident was quite pleased because it was what they call a champagne tap. So cerebral spinal fluid came out and it was just a little off-white, kind of clearish fluid. There's no blood in it. So that was quite, I think she was very happy to see that. And just to give you an idea how long ago this was, she actually wanted me to take a picture of her. She already sent the fluid to the lab. Didn't think about this ahead of time, but then was like, hey, this is kind of a momentous event. Can you take a picture of me? So we filled the fluid with water, and then I took a photo with her. And man, it wasn't a flip phone, but it must have been like the first generation iPhone because the quality was very, very grainy. And it was okay, but it was a long time ago. Anyways, fast forward to residency. When I saw my first lumbar puncture residency, this was with a patient who had HIV and came in with confusion, and no one knew why this patient was confused. And so with HIV, the first thing you want to think about is that it's some kind of infection. People with AIDS have a very compromised immune system. They're more prone to infections that normal people don't get. Some of those infections can infect or affect the brain. And so one thing on our mind was cryptococcal meningitis. And so for this reason, we needed to do a lumbar puncture. So I was working with a infectious disease specialist who at first had me scrub in and assist him as he did the procedure. And then I got to watch to see exactly how it was done. And so that was kind of like the C1 step. And so already this has a lot of value. It's even though it's not as hands-on as the simulation exercises, you're watching it on a real person. You actually get to see how everything's done, including all the ancillary stuff, like getting the sterile gown on, making sure the space is clean, and numbing the area first. All of that stuff is things that you don't really see with just the mannequin. So then fast forward to later in the rotation, is finally my turn to actually do one myself. And so here, he didn't just turn me loose. The specialist didn't just send me in there by myself. He actually scrubbed in with me, and then we palpated the landmarks, found exactly where to go. And then once my instructor or supervisor confirmed that this was the right place to go in, only then did I move forward with the procedure and actually insert the needle in. And so there you've got someone who guides you along the process, but they're right there. So if anything happens or anything goes wrong, you have a much more experienced practitioner who can take over even if needed. So now, you might be thinking, wait a minute, this is a real person we're talking about. And if it were me, I wouldn't want somebody who's just doing this for their first time working on me. And so for this, we do get obviously consent. People, when they go into a teaching hospital, you sign a form saying that you're okay with doctors who are still undergoing their maybe residency or specialty training working with you, of course, under the understanding that they're going to be working very closely with fully trained attending physicians. So now going back to my lumbar puncture example, I don't even remember how many I did, but even during the course of that infectious disease rotation, I probably did over 10 of them. Because anyone who comes in with cryptococcal meningitis, and by the way, that did end up becoming cryptococcal meningitis. We confirmed that with analysis of the cerebral spinal fluid. Now, when you get that diagnosis, you don't just need one lumbar puncture, you actually need the procedure to be repeated. This is to avoid having too much pressure buildup from the cerebral spinal fluid, which can risk further complications. Anyway, it was plenty of opportunity to have more experience with this procedure, and eventually I got signed off on it and would start teaching residents how to do the procedure myself. And so there you go. That's the simulation, then see one, do one, teach one. I applied the same process to all the other procedures that I had to learn. Paracentesis, that's where you take a needle, drain fluid from the abdomen. Thoracentesis, that's this same kind of thing, but it's draining fluid from around the lungs. Central line placement, that's placing a large IV in a vein in the neck. Also hemodialysis catheter placement, that's another procedure I learned. Kind of the same thing, except it's a much larger catheter that can be used with a dialysis machine. Also did it with arterial line placement. That's a catheter that goes in the radial artery for hemodynamic monitoring. And some of my colleagues in residency learned other procedures like intubation and joint injection. Okay, that's a quick introduction into how doctors learn procedures. I hope you found this video to be helpful. Here's another one you can check out here. And if you like more medical content like this, go ahead and hit the subscribe button, and I'll see you guys next time.